with me, and her name is Melanie Kearney. She's of Melanie Kearney. She's from Bloemfontein, Afrikaans, and I'm so excited to have her with me today. Melanie, are you here? Let's see if I can get you in. Yeah, there she is. Hello.
Hi, I'm here. How are you? Yes.
Yeah,
Hi.
I'm so glad. It's so lovely to have you, and man, it's just difficult to get time together, so I'm just so grateful for this time that we can spend together.
Me
Because
too.
we've got some really awesome things to share. Melanie, we share obviously a passion, and that is midwifery, you know. So we're both independent midwives. Tell us a little bit more about yourself, who you are, where you work, what would you love to share with the world?
Okay. Hi, my name is Melanie. I'm a Bloemfontein-based independent midwife. I am a mom of 2 boys and a wife to a husband named Burger. We have actually an Irish surname, but we are so very much Afrikaans. So our firstborn's name is Reinhard. It means pure of heart. And secondborn is Colin. His name is destined and victorious. He lives up to his destiny and he's victorious about everything. So busy running around with both boys, but absolutely loving it. I've been a midwife since 2007. I completed my studies, my bachelor degree in 2006 at the University of the Free State, and been in Bloem ever since. I had the privilege of working in an active labor ward in Bloemfontein Medi-Clinic for 10 years, and then the Lord brought hysteria over my path, and he gave me the opportunity also to further my studies as an advanced midwife. And I've been practicing independently since the beginning of 2017 at our practice called Hysteria, Women's Wellness Clinic.
Wow, that's amazing. So you're definitely a pure midwife, passionate to the core, have been in midwifery for many, many years. That's wonderful. And you are currently working for Hysteria, you said. Tell us a little bit more about your center.
Oh, wow. We are in the center of Bloem in the we call West Dean in the suburb. We have been celebrating our 5th, I wanted to say anniversary, but our 5th year open as an active birth unit, and we are very close to Bloemfontein Medi-Clinic, so that is our main feeding hospital for our backups, and we have great support from the gynecologists in the private sector, both Medi-Clinic and Life Rosepark. We also do have moms coming to us with government backup that don't have a medical aid, and that we also then feed if needed as a backup to our district and secondary hospitals in Bloem. We are an active birthing unit, as I said, so we give antenatal through intrapartum birth on the premises. And also we have a well mom and baby clinic on premises as well. We are 3 advanced midwives practicing currently, and then we have a basic midwife as well that attends to our baby clinic with weight measurements and immunizations. And we take in low risk moms having a different choice, having a different view of childbirth, that don't necessarily want to have their birth in a hospital setting. So giving them an opportunity to have a safe environment, but also with women supporting women and midwife-led care, and also then with the support of obstetrician care if needed and when needed.
Wow, Bloemfontein is so lucky to have you and Hysteria. That just sounds absolutely amazing. It sounds like the dream. Sounds like what every community needs, right?
Yes.
Yeah, no. So well done for all of you and what you achieved there, and that's really beautiful. I came across a beautiful testimony from one of the moms that you've looked after, Melanie, sorry. And
it's fine. Melanie will do as well. It's fine.
You listen to that, hey? Melanie, so it was actually a testimony of a mom that had a caesarean section, and obviously our approach is to have a natural birth, and the less interventions the better, but sometimes a caesarean section does happen, and she mentioned that she had a sensitive caesarean section, and then we shared it on our Facebook with permission from you guys, and then received a few questions from what is a sensitive cesarean section. So I thought, let me ask you, what is a sensitive cesarean section?
So basically, we wanted to be more sensitive to the needs of a baby born with a cesarean section in a more clinical or a more medicalized environment. So in a nutshell, a sensitive cesarean section is, it allows basically the birth to continue as exactly the same manner, except now in a theater environment. So attending to the newborn's needs as they were born from a vaginal birth, they got placed skin to skin with their mom, they got time literally to bond with their mom for a while. They got time to get used to their new environment. So now, usually with a cesarean section, the baby is taken out and shown to the mom and dad very quickly, and then the baby is then taken to a nursery in an incubator while the mom is left alone in theater. So we wanted to just literally typics out those parts that the mom and the baby are not together and enforce non-separation of the mother and baby. So we've started doing this, what we call the sensitive cesarean section, to be more sensitive to the newborn's needs. So we are delaying the routine neonatal care of the newborn, not excluding it. We're just saying, wait a bit, let's just get that baby out into the new environment. Of course, that the baby is healthy. It's our priority to make sure that the baby is adapting well after birth. And then we stay with the mom in theater, putting the baby's skin on her chest as soon as possible. After drying the baby, we do the neonatal care like the cord clamping, but we do delay the first eye prophylaxis and the vitamin K administration so that the baby can be granted to go through their first adaptation phases after birth, to allow them to get to a place where they feel comfortable to either start suckling or then exploring mom's breasts, or then just maybe falling asleep, but in a controlled, safe environment without being taken away from mom. And even dad can stay with mom in the theater as well. So now a baby is not taken away, the mom is not left alone, the dad is not taken away, everyone stays together.
It sounds like a no-brainer to me.
Basic.
Yeah. I mean, you would wonder why it's not standard practice and why it is something that we need to call a sensitive C-section. But I think lately there's become much more awareness for it and the importance of this, and that's why you are doing it, obviously. Tell us a little bit about the benefits of why this is not just a feel-good thing. It's actually really important.
It is definitely, and it's evidence-based. So at the end of the day, there are so much good outcomes, and we focus our care at Caesarea as well on evidence-based practice. So at the end of the day, the big thing is, if we can keep to the statistics, let's go there. Thermoregulation. So we all know that a newborn baby does not have the capability to warm themselves yet. So their core stays cold basically. So you can wrap them in as many blankets as you like, but they can't regulate their own heat. So they need something warm. And then we think, okay, put them in an incubator. And yeah, okay, but the incubator can't regulate the temperature, but a human body can. So that's why skin-to-skin contact is so important. Also then benefiting, giving the baby the healthy nutrients on the mom's skin. We talk about the microbiome that the baby can get exposure to, same as the baby had in the womb. So now the baby can get immediate exposure to the healthy organisms on the mom's body, to start with gut colonization. And now the baby don't need to work so hard using all their energy just to stay warm. They can literally focus on gas exchange. Remember, for the first time after birth, the baby's lungs are filled with blood. They were filled with amniotic fluid since in the womb. That's all they know. The placenta has done all this oxygen and carbon dioxide and taking in and out the gas exchange. Now the lungs need to do that for the very first time. So for a newborn baby, it's actually more important to stay warm than to oxygenize. So they would much rather use their energy to stay warm. And then you have a baby that is tired, their blood sugar levels are low because they don't have enough ability to just get the oxygen going. So what happens? They're blue. They are cyanotic, they don't have good perfusion. So if we basically just keep a baby warm, skin to skin, in a safe environment, with a known environment, the mother or the father, if the mom is not awake maybe during, or she doesn't feel well, we can go to the dad's chest as well. I'll even put the baby on my chest, but I really do not want to put a baby in an incubator if it's not needed. So then we can give that baby thermoregulation. The next thing is also we can let go of the baby's stress response. We can minimize that so that the baby can adapt to an environment that is known to the baby. So then if they're not in the stress response, they also are not using much of their energy levels. So then we've sorted out the hypothermia, we've sorted out the hypoglycemia, or the low blood sugar levels, and now we also have an improved breastfeeding outcome, because the mom is not stressed, the baby is not stressed, the baby is warm, the baby is ready to start consuming not just hunger and food, but to latch on a breast to get emotional comfort. And then bonding time. Mom, dad, and baby, the whole childbearing family can stay together. And now that's only a few, but we can keep the mom and baby together in a clinical medical environment like a cesarean section.
Awesome. You're obviously super passionate about it. I can hear it in everything you say. So just to summarize, it's obviously incredibly important for the thermoregulation, as babies can do that themselves. And then very crucial is the bonding aspect of it, bonding between baby and mom or dad, should it be. And then the latching, early latching, the microbiome, all those beautiful things that we promote very much in natural childbirth, in that first golden hour, no separation of mom and baby. So even if the listeners aren't aware of all those benefits, they are very important for a natural birth too. So that's what we're trying to achieve with a cesarean section, to really get most benefits still, of what has gone lost with an operative birth, and really
so
minimize the risk.
Definitely, yes, definitely, because a healthy mom needs to stay with a healthy baby.
Yeah.
If a baby is able to stay with the mom after vaginal birth, skin to skin, let us not change when the route of birth is changing. Let's not change the care that the newborn receives. We know cesarean section sometimes is because of a higher risk or a more medicalized environment, or there was a need for the Caesar to happen. So yes, we will acknowledge that, and we will never take away a specific type of care that baby needs. But if everything is excluded and we saw that the baby is healthy and is adapting well, keep them with their mom. That's basic.
Awesome, yeah. So Melanie, let's talk a bit about the practicalities of this now, because we are in a theater. There's lots of sterile gowns and green cloths that are not supposed to be touched. Yes. And there's a lot of people. There are doctors that are doing their job. How do you go about making this happen? What has your experience been?
So initially, when we started with the Sensitive Cesarean Section, it was actually an idea my colleague had, Charne Human, and she had this friend giving birth with a cesarean section, and it was just after her coming back from a sensitive midwifery symposium with Sister Lillian, actually in 2008, and they started talking about just in controlling the environment a bit to be more sensitive towards the newborn's needs. And she had this friend going in for a season, said, but we'll try that in theater. So eventually we started just by putting the baby on the dad's chest, skin to skin, instead of taking the baby in an incubator to the nursery. And over the years, we got to a place where we saw that there's enough space on the mom's chest. So as that drape is here in front of her, her whole chest upwards is available, and a newborn baby is not that big. So then we just ask that the screen that they place is lifted up a bit higher, basically. So the mom's dress is loosened at the back. So the midwife will then be arranged pre-cesarean section date, which will now be one of our stereo midwives. And they usually go with you to theatre. So they are there to receive the baby directly after birth. So the gynecologist or your obstetrician still performs the Caesar exactly the way that they want to. You are genuinely just focusing on the baby after birth. So when that baby is now born, the midwife going with you to theatre will place your baby on your chest. When there is now minimal, we're not in the way of the doctor, so we are not harming or influencing the sterility of the theatre. We are doing our own things on the opposite side of the screen, basically. So now the baby is dried, the baby is cared for. We place a nappy on the baby. We don't even take the baby to the MECO, to the overhead warmer, to do our first examination. We do it with the mom literally here on her chest, so that the baby is not even removed or separated an arm's length from her. So before you receive the baby, the midwife will also be sterile. She'll be scrubbed up with her total theatre attire, and then the gynecologist, after handing over the baby after birth, can still continue with the Caesar, not being contaminated, and we as the midwife can continue care with the mom and the baby, now not being sterile anymore.
I love it. Yeah, it sounds very doable, and with a little bit of innovation, it can definitely be done, and willingness from the team.
Yes.
Have you found opposition about this with the hospital staff, with the doctors? How was that for you?
Unfortunately, I think luckily me and Charne is quite persistent in what we do, and I think we don't easily take no for an answer, because we do stay with the core and we stay with the basics. And I think over the years we've shown that we are not there to play games. We are there for the core, the birth of a baby, the birth of the mother. And it's much more than just taking out a baby from a stomach. It's much more than delivering a baby, because babies are not delivered, they are born. So those basic things, let's try to do that. So we've had a few ups and downs with more the anaesthetists were sometimes thinking that we are not giving them chance to work with the mom and observing the observations. But these days, I want to say for the past 7-8 years, the doctors have really accommodated us. They know we are there for a wonderful reason, and we have wonderful working relationships with both now the anesthesiologist and the obstetrician, and everyone is so just helping when needed. So when the mom, for instance, don't feel well and her blood pressure is down for a bit, we sometimes then place the baby on dad's chest, and then the anesthesiologist can still attend to the mother and make sure that their blood pressure is stable, and then she's fine. So she's still literally been treated in theatre the way she would have been if her baby didn't stay with her. So her ECG stickers are still on her chest. We literally just move them a bit more towards the edge and not literally on her chest. But they are really accommodating us. They see that this is to benefit both mom and dad. And it's not my birth. It's not their births. It's the mom's birth. They are the ones that will look back on this, maybe the only experience they will ever have birthing a child, looking back and thinking, oh, thank you. I remember this person helping me with that, and I remember this person helping me with that. So I'm also going to look back and thinking of all the births that I've been with. But that mom and dad might never have the ability to birth again. Mm-hmm. So let's make this extraordinary.
Wow, exactly. Wow, that's really well done. That's really amazing, and I hope you are creating waves. And I know even this talk today will inspire a lot of midwives that are listening in, and birth workers. So well done for the whole team and for everyone to be adaptive. And I think with teamwork and team effort, we can we can go far. Melanie, just a few words for maybe women that don't have access to midwives like yourself, what would you like them to know? Is there something that they can maybe just ask the midwives that are with them in the hospital?
Definitely.
Or just tell us a bit.
I think that's the important thing, Margreet, is ask. When you are planning your birth, plan your birth. If you know you are going to have a Caesar, or you are planning a natural birth and you have that idea of maybe, remember, a vaginal birth is not always guaranteed. So my suggestion would be plan for both. Be ready that if the need comes for the cesarean section, and that you don't lose all ability to stay focused, that it's not such a shock. So if you do know that you are going to have a Caesar, or it might be a possibility, please ask your treating provider, either your obstetrician or in the hospital that you are planning to have your birth. Ask them what's the options for non-separation of mother and baby. If you go into a new hospital and ask them, I want a sensitive cesarean section, they might look at I wanted to say, maybe just where I left off, if you go into a hospital asking for a sensitive cesarean section, they might not know what you are talking about. So if you rather go in asking, I want my baby to stay with me at all time, they will probably say, yay, we will put your baby on your chest while we do our paperwork. But having a sensitive cesarean section or a gentle cesarean section, or what do you want to call it, it doesn't matter. It doesn't mean if your baby stays on your chest for 10 minutes after birth, you had a sensitive. Your baby should not be taken away at all. If the baby is healthy and the mom is healthy, and someone can stay with you in theater. So mostly time is the thing. They will say that the hospital personnel don't have the time to stay with you so long. So that's why we as independent midwives are able to give the service at Bloemfontein Medi-Clinic. And we have actually, I think it was in 2018, that we sat down with hospital management and we actually drew up a protocol that is now a Medi-Clinic Bloemfontein hospital protocol, sensitive cesarean section. So the hospital know why we are there. They know we can do this. They know we're legit. They know what we do. And we say that the parents have given us permission to work with their children. And if I bump your baby's head accidentally, it's not Medi-Clinic's fault. It's my fault. I won't bump your baby's head though. But you get what I'm saying. So we have such an amazing relationship with our hospital in Bloemfontein. And that would be my suggestion for people in other cities and other towns. At least ask. Ask if someone can stay with you. Ask if your baby can be kept with you skin to skin. Instead of taking the baby to the nursery, have your baby on your chest. So that will be my first thing. Ask. Just ask.
Yeah, absolutely. I love what you said earlier, Melanie, is that you need to plan for this, right? So you plan for your natural birth.
Planning.
Or you plan for, but also consider you might end up with a cesarean section, and think it through too. You know, what are important things and how can we minimize the risks of Caesars, because we know there are risks involved. So definitely plan and ask. So there we go. I also really love hearing that you've written up a protocol. Would you guys be open to share that with Sensitive Midwifery, and that we could help empower some other midwives?
Yes, definitely. I would make sure and ask even Charne, my colleague, and our company director, if that would be a possibility, because we really spend so much time getting the legalities in place from Medi-Clinic side, but from our side as well, to make sure that this is really a doable, safe, practical protocol that can be in place. And it's actually taking off so much workload from the ward personnel, because you stay with the mom even for an hour or two after the birth. So you are there to help to breastfeed the baby for the first time, or latch the baby. The baby doesn't need to be admitted, so it's not so much extra paperwork immediately. You are doing the identification. We do delayed vitamin K, so you will do that before you are leaving the mom and the baby. And if you have any hiccups, the pediatrician is literally just a phone call away. And I think while we were in Medi-Clinic, both me and Charne worked there for 10 years. So we know the rhythm, we know the ward politics, we know how the different setting in every ward, the baby room with the postnatal ward, with the labor ward, how everything fits in with one another. So I think if you are planning where you have your birth, visit your hospital where you are planning to have your birth. Will it be now a natural birth, vaginal birth, epidural birth, cesarean section? It doesn't matter. Go and have a look. Meet the personnel. Check what's the possibility of someone spending a bit more time with you. Get to know them. Join their antenatal education classes so that you are able to have a solid structure or a foundation to be able to ask questions, and that you have trusted resources. I think that's the most important thing as well. Have trusted resources.
Yeah, absolutely. I mean, in these days and times and age, we really talk about woman-centered care and patient-centered care and so forth. So it is really not strange to own your birth and own the processes and speak up and go visit a place. And it is a really amazing life event, and you can co-create that event. So it's not like a sickness and you just shut up and whatever they do, like, oh, they are the gods out there.
No.
So we want to empower them out there. Melanie, one more thing that came to my mind is to ask is how does it work with payments? Because mothers might ask, like, yeah, but I've already got my hospital bills and you pay for the hospital midwives. Is it extra cost involved? Is medical aid covered for you guys? How does that work?
All right, so there's actually a billable code on the medical aid. So it's a global code that specifies it's a hospital birth with midwife service from admission up until discharge. And some medical aids do pay it from your in-hospital benefit plan. So some of these are discovery. It doesn't matter on what plan you are, even if you're on a key care network or on a Delta or a Classic, they do pay it from your in-hospital benefit, and you don't have to pre-arrange anything with your medical aid. So we use the authorization number you have for your cesarean section, and we submit the claim with the procedure code, so the ICD-10 codes or anything that you have loaded for your gynecologist or your obstetrician. That does not change. BestMed also pays for the service from your in-hospital. James does. I think MediHelp as well. One of the smaller funds that do not pay is Momentum. Unfortunately, they say it's not within their scheme rule. So even though it's a code that's been used with all the medical aids, the same code, they say it's actually the responsibility of the hospital's midwives to give you the service. So if you need to hire someone from outside, it's actually the patient or actually the hospital's responsibility to reimburse this independent midwife, because then why was the hospital not able to give you the service? So we know for our Momentum patients that they have a cash fee that they pay pre-procedure, but for the patients on Discovery, James, BestMed, MediHelp, I'm sorry if I left one out, but we claim, and our amount that we claim is much lower than the amount set for that code on the medical aids.
Well, that's amazing to hear. Well done for those medical aids. I can imagine for women that have been in a hospital setting and maybe have opted for an elective cesarean section that it would make sense to make use of the hospital midwife staff. So that's why we want those midwives to also know about sensitive cesarean sections. But definitely for the continuity of care, if you would have transferred a client in because she needed intervention, then, oh man, that's first prize. So wonderful if you can then continue and finish the job with your sensitive care. So I love it. Yes, lots of valuable information. I'm sure you inspired a lot of people with coming on today's show. Thanks so much, Melanie.
Privilege. Thank you so much for inviting me, Margreet. It's really been an absolute joy to share with you what we do, an extra part of what we do, and I really hope that there's a few moms and midwives out there that can, either if they're not still yet doing the service, that they can start doing the service. And if we need to train people, we'll train people. If we need to give information, we'll give information. So basically, don't take the mom and the baby away from one another. Point. Done. Dusted.
Point. That's it. Thank you so much, Melanie.
It's a pleasure. God bless.
Keep up the good work.
Margreet.
Take good care of yourself.
You too.
Bye. So that was Melanie from Bloemfontein. If you've been inspired and you are from that region, if you are in Bloemfontein or I think even in the environment, go check those midwives out there. Absolutely amazing. Hysteria Clinic, Women Wellness Center. I'll put the link in our notes, so go find them. So that was us for today. Hope you enjoyed that, and we see you next time. Bye.